Good day, students. In this lecture, we will be discussing about hypersensitivity. You have discussed in your previous lectures about the basics of immunology, and now we will go to the specific part wherein we will talk about the disorders of the immune system. So what is hypersensitivity? So hypersensitivity is a heightened state of immune responsiveness and an exaggerated response to a harmless antigen, which results in injury to the tissue, can cause a disease, or even death. So hypersensitivity happens when our immune system is unable to process the antigens in our body or the antigens from the outside environment to our body and reacts in a certain way that is already harmful to the self. So we have four major types of hypersensitivity reactions: type 1, 2, 3, and 4. And they are called as IgE mediated, cytotoxic, immune complex mediated, or T cell mediated. So they vary in their onset. Some are immediate and some are prolonged, and these are some of the examples of the conditions that fall on the specific types of hypersensitivity reaction, which we will talk about later. So the divisions of the hypersensitivity is based upon the passivity of antibody transfer or by immune lymphoid cells. Again, the types of hypersensitivity reaction are named as such depending on the mediator and also on the onset of action. So the type 1 is more of IgE mediated or immediate type of hypersensitivity. So what are the common manifestations of a type 1 hypersensitivity? The common manifestations will be systemic anaphylaxis or localized anaphylaxis, and the examples of those are when you get hay fever, asthma, hives, or some food allergies, and eczema. Type 2, on the other hand, is mostly IgG-mediated cytotoxic hypersensitivity. So the general idea in a type 2 hypersensitivity is that when an antibody directed against cell surface antigen mediates cell destruction via complement activation, or what you know as the antibody-dependent cellular cytotoxicity. Type 3, these are immune complex mediated hypersensitivity, and what happens is it is similar to type 2. However, the antigens in a type 3 hypersensitivity are more of soluble. So there are antigen antibody complexes that are deposited to different tissues, and the deposition of these complexes triggers a complement activation, thus eliciting an inflammatory response. So what are the examples? Are localized Arthus reaction or generalized reactions such as serum sickness, vasculitis, and some glomerulonephritis. Type 4 is also termed as cell-mediated or delayed type of hypersensitivity. So it happens when a sensitized T cell release cytokines that activates macrophages or cytotoxic T cells, which mediate direct cellular damage. So what are the typical manifestation of type 4's hypersensitivity? These are your contact dermatitis and tuberculosis, and also graft rejection. So again, as an overview, in type 1 reactions, there are cell-bound antibody that will react to an antigen to release physiologically active substances. In type 2 reactions, those free antibody reacts with antigen that are associated with cell surfaces. In type 3, hypersensitivity, the antibody reacts with a soluble antigen and they form complexes that precipitate in the tissues. And in both type 2 and type 3 hypersensitivities, the complement system plays a major role in producing tissue damage. And lastly, in type 4 hypersensitivity, it is due to sensitized T cells, unlike type 2 and 3, which are due to antibody deposition. So we go to specific types of hypersensitivity reactions. So these are illustrated differences of type 1, 2, 3, and 4. You see that the antigen is bound to the antibody that is located on the cell surface. And after the antigen will bind to that antibody, you will see a release of mediators from that cell. In type 2, it is different in such a way that the antigen is bound to the cell surface and the antibody will be the one to bind to that antigen which is in the cell, and once an effector cell will identify that complex, it will either activate a cell-mediated response like macrophage or complement system. In type 3, it's still an um, immune complex, but these are of soluble antigens and they deposit to tissues, and the deposition of these immune complex will trigger the complement system or neutrophil and will cause tissue destruction. And in type 4, the antigens are recognized by T cells, and when the T cells are being sensitized, they will release cytokines that will trigger the inflammation. Okay, so remember the different um, binding mechanisms of each hypersensitivity reaction and the mediators. Now, for your type 1 hypersensitivity reaction or the allergic type of hypersensitivity reaction or atopic type of hypersensitivity reaction, and also termed as immediate. So there is a sensitization that will happen. So a formation of antigen-specific IgE attaches to mast cells, and this will result activation of the degranulation of the um, mast cells. So there are antigens that will trigger formation of IgE and are called atopic antigens or allergens. So what is atopy? The atopy refers to an inherited tendency to respond to naturally occurring inhaled and ingested allergens with continued production of IgE. Diba? We have different sensitivities to different allergens. So, you will notice na may ibang tao, halimbawa, makakaamoy lang ng certain type of odor or mag-expose lang sa certain type of allergen like dust or dust mite. It will trigger such an allergic response that is not similar when another person is exposed to that kind of allergen. So that type of tendency to respond can be inherited, and that is termed as atopy. So in your immediate or type 1 hypersensitivity, the IgE antibodies that are specific to environmental antigens will is usually the most prevalent mechanism. So the immediate hypersensitivity disease, commonly grouped under allergy or atopy, usually causes um, these reactions because of the activation of the interleukins 4, 5, and 13. So they will produce Th2 cells or trigger the production of Th2 cells and the production of IgE antibodies. So these IgE antibodies will bind to mast cells, and once they attach to a specific allergen, they will immediately mediate a response wherein there will be degranulation of the mast cells or eosinophils, and that in turn will result to inflammation. So that's what happens in an immediate type of hypersensitivity reactions. So you can see in this table that there are different mediators of immediate hypersensitivity. So a cross-linking of surface-bound IgE on basophils and mast cells by a specific allergen, just as what was shown earlier, causes the changes in the cell membrane. So nare-release yung mga substances that are found in the cytoplasmic granules of those cells. And depending on the type of substance released, that mediates a specific type of response. So usually, di ba immediate nga, so it occurs 30 to 60 minutes after exposure to that type of allergen. So for example, if na-release yung preformed histamine from the granules, it will trigger smooth muscle contraction, vasodilation, and increased vascular permeability. Or naman, prostaglandin 2. It will also trigger vasodilation and increased vascular permeability. That's why, histamine, if merong isang tao na nagkaroon ng asthmatic attack, di ba parang hindi sila makahinga because the bronchial smooth muscles are contracting, tapos nagiging limited ang space for the airways. That's why they are given antihistamines to stop that allergic reaction. So what are the principal effector cells of your immediate hypersensitivity? They are the mast cells, and they are from precursors of the bone marrow, and they are delivered to specific tissue sites to mature. So what are the different testing methods for type 1 hypersensitivity? Meron tayong tinatawag na in vivo skin tests, yung cutaneous and intradermal test. So there are two skin tests. These are two skin tests that are most oftenly used. So they are effective in and very specific in showing hypersensitivity. However, they are invasive. So they can cause discomfort to the patient. So pag cutaneous, ilalagay lang yung antigen sa body, ay sa skin, tapos titinan yung allergic reaction. Pag intradermal test naman, you introduce a higher amount of antigen, and they are called intradermal kasi yung wheel of the antigen concentration will be introduced to the dermis, and titingnan kung merong inflammation or wheal formation na mangyayari. And if that happens, it will show that the patient is allergic to that kind of antigen. So you will see if na-introduce na yung antigen, there will be vasodilation and congestion, activated mast cells, and there will be leakage of plasma fluid and protein, which will cause edema in the surrounding tissue. Now, for your in vitro tests, we have what we call as competitive radioimmunosorbent test and radioallergosorbent test or RAST. So in vitro tests involve measurement of the total IgE or the antigen-specific IgE. So itong mga test na ito are less sensitive than skin test, yung cutaneous and intradermal. However, hindi nakakakos ng trauma to the patient because we will not introduce antigen to the patient. So, total serum IgE testing is used clinically in aiding for the diagnosis of allergic rhinitis, asthma, or other allergic conditions. So, they can indicate if the patient, they are indicated if the patients are symptomatic. So in your competitive RIST, they use radio-labeled IgE to compete with the patient IgE for binding sites on a solid phase coated with anti-IgE. So that will be read after, and that is a way of measuring total IgE. However, there are non-competitive ways of RIST wherein the anti-human IgE is bound to a solid phase like this, and the patient serum will be allowed to interact to the anti-human IgE, and then the labeled anti-IgE will be measured, and they will check if how high is the reaction, so that will determine the concentration of the IgE. So the label can be enzyme or fluorescent substances. Now in radioallergosorbent test or RAST, there will be a non-competitive solid phase immunoassay in which the solid phase is coated with specific allergen and reacted with the patient's serum. Tapos ile-label na naman yun and i-read yung concentration of the enzyme labeled anti-immunoglobulin. So, pag radioimmunosorbent test, ang minimeasure is ang IgE. Pag radioallergosorbent test, ang minimeasure is yung antigen-specific IgE. Meron ding mga bagong allergy testing ways ngayon wherein there is a miniaturization of diagnostic testing for multi-allergen diagnosis and with a low sample volume and high output capacity. Now for your type 2 hypersensitivity reaction, it is also termed as cytotoxic hypersensitivity because the antigen is bound to the cell surface. So what are the reactants that mediate this hypersensitivity? They are your IgG and IgM na antibodies. So these antibodies are triggered by antigen found on cell surfaces, and those antigens can either be of self or of heteroantigens. So some examples of the cells that are mediating these kind of hypersensitivity reaction are your macrophages, neutrophils, eosinophils, and NK cells because they have Fc receptor that binds to the Fc part of an antibody. So, in type 2 hypersensitivity reaction, they involve antibody-mediated destruction of the cells. So, this destruction can be due to complement system activation, and that will result in cell lysis of the cell that is attacked by the complement. Another example also of this type of cytotoxicity is the antibody-dependent cell-mediated cytotoxicity, where the Fc receptor will bind to the Fc receptor of the antibody on the target and promote killing. So makikita nyo dito, there are three major ways in which type 2 hypersensitivity reaction happens: the opsonization and phagocytosis. So the antibody will bind to the antigen on the cell surface that will trigger opsonization of the phagocyte and will result in phagocytosis. Or instead of the phagocyte being activated, what will be activated is the complement. So still that will result to inflammation and tissue injury. Or the antibody will bind to a self antigen, and the antibody will stimulate the receptor even without the hormone. So that happens as a self-destructive hypersensitivity reaction. Remember that the antigen that is detected by the mediator of the hypersensitivity reaction can be a self or heterotype of antigen. So your hemolytic disease of the newborn is a typical example of type 2 hypersensitivity reaction. So the mother will make an antibody against an antigen that is found in its fetus, because that antigen is not found with the mother. For example, in cases of RH, hemolytic disease of the newborn, if the mother is lacking the RH antigen, but the baby has the RH antigen which it inherited from the father, when the mother detects the antigen found in the fetus but is not found in the mother, it will stimulate the formation of IgG antibodies in response. And your IgG antibodies, as what you have learned, has the capacity to cross the placenta. And when they do cross the placenta, they will bind to the antigen found in the RBCs of these fetus and will stimulate an immune response. So usually, for the first pregnancy, this type of immune response does not happen because it will take time for the mother to develop antibodies against that specific antigen. However, when the mother do have a second pregnancy, when they will detect the same type of antigen in the fetus, now it will elicit a strong immune response and might injure and kill the fetal tissue. And for those type of severe high hemolytic disease of the newborn, we term that as erythroblastosis fetalis. So thankfully, because of the technology we have today, we are able to prevent this kind of hypersensitivity reaction between mothers and their fetus by introducing a ROGAM, or a type of antibody that binds with the RH antigen positive cells, and it will now prevent B cell activation of the mother, kasi it will already bind with the cells of the fetus. So now it will not be detected by the immune system of the mother, thus preventing this kind of condition. So aside from antigens, some drugs can also passively bind to RPCs, and when there are antibodies that are directed against this type of drugs, they can bind to those drugs and elicit lysis of the RBCs. So a faulty immune system of a patient can cause an autoimmune disease against the person. So if um, antibodies will be formed against a specific antigen of a normal tissue in the patient's body, it will trigger an immune response and cause destruction of that cell. For example, in the kidneys, if an antibody will be formed against specific antigen of the kidneys, like specific part of the glomerulus, it can cause kidney inflammation and damage. So that is a type 2 hypersensitivity reaction when the antigen is bound to the cell and the antibody will bind to that antigen found on a cell surface and elicit an immune response. That is your type 2 hypersensitivity. So a way of testing hypersensitivity reaction type 2 is Coombs test. So Coombs is a scientist that discovered the anti-globulin test in 1945. So he was able to made it possible to detect antibody or complement on red blood cells. So there are two major types of Coombs test: the direct antiglobulin test or direct Coombs test, wherein we detect um, in vivo coating of red blood cells, and the indirect antiglobulin test or indirect Coombs test, we detect an in vitro coating of red blood cells. So in direct Coombs test, we will know if there is an ongoing type 2 hypersensitivity reaction. In indirect Coombs test, we are going to test if there is a possibility of type 2 hypersensitivity if we will introduce this kind of substance or, for example, blood component to a patient. Okay, so in direct antiglobulin test, this one, um, we usually detect the presence of IgG coating or complement coating in the red blood cells of the patient. So the presence of complement products in the body will indicate that there is an antigen-antibody combination that triggered the complement pathway and thus produced the presence of split products of complement proteins. So the direct antiglobulin test can help diagnose transfusion reactions, hemolytic disease of the newborn, and also autoimmune hemolytic anemias or other types of hypersensitivity reaction. So the blood component that we use are usually um, EDTA, anti-coagulated blood. Now for your type 3 hypersensitivity reaction, um, this is similar to your type 2, wherein there is an antigen-antibody complex that binds the complement, causing damage to the particular tissue. However, remember in type 3 hypersensitivity, that the antigen is soluble, thus the complexes that are formed will precipitate out of the serum, and um, when they are not cleared by the phagocytes because the immune system is overwhelmed, these complexes will deposit to the tissues. That's why type 3 hypersensitivity is also referred to as immune complex type of hypersensitivity reaction. So usually the deposition of the immune complex is influenced by the relative concentration of both antigen and antibody. If there is a large amount of antigen present, the sites on antibody molecules will become filled and cross-links are not easily formed. In cases of antibody excess, there will not be a formation of a lattice complex because of the relative scarcity of antigenic determinant sites. So the small complexes will cause precipitation, and the precipitating complex can deposit on some tissues. So in this example, there are circulating immune complexes, and the immune complexes will deposit on the blood vessel. And now the complement and FC receptor mediated recruitment of inflammatory cell will now trigger the immune response and thus cause damage to the blood vessel. So some of the immune complexes can deposit or settle in the basement membrane of the lungs or kidneys and joints. So they induce an inflammatory response, and usually they bind complement factors C3A and C5A, which are your anaphylatoxins, and this type of reaction will trigger the immune response. The Again, this is a flow chart showing the immune process of a type 3 hypersensitivity. When soluble antigen combines with an antibody, the complexes can precipitate out of the serum. So the in situ formation of these immune complexes most likely results in the pathogenesis of this inflammatory reaction. So when the antigen-antibody complex is absorbed in the tissue, it will trigger a humoral immune response. So they will cause that, di ba usually, yung antigen-antibody complex can be cleared by the phagocytes. But if they are adsorbed in a specific site of the tissue, so phagocytic system is not possible anymore. And these tissue-bound immune complexes are very strong activators of the complement systems, and this will now trigger a major immune response by the chemotactic factors that it elicits, and more neutrophils will go to the site of the inflammation, and it will cause tissue damage. So that is what happens on a type 3 hypersensitivity. So there are localized types of hypersensitivity reaction. So when the antigen is introduced in the skin, it will trigger a binding to an immunoglobulin. And the immune complex will be detected by an mediator cell or will cause complement activation. So when we say localized, we can have an example of the Arthus phenomenon or the Arthus reaction. So the Arthus reaction is triggered by the combination of a complement fixing IgG antibody. So the local injection of the antigen will cause the circulating antibodies to bind with those antigen. So when that antigen has penetrated the skin of an individual who has preformed IgG antibodies, these immune complexes can bind to Fc receptors of most mediator cells. So they will cause degranulation of inflammatory cells, and these degranulation will result to release of C5a or C3a. So these anaphylotoxins will cause vascular dilation, accumulation of neutrophils, and increased vascular permeability. So this is a local type of type 3 hypersensitivity, which can cause local inflammation or platelet accumulation, or also blood vessel occlusion, which will eventually lead to necrosis of that site. We also have a generalized type of hypersensitivity reaction when large amount of antigens will enter the bloodstream and bind to antibody. So there are a large number of immune complex that will circulate all throughout the immune system. So that cannot be cleared by phagocytes and thus will result to tissue damaging reactions. So usually the initial event in this type of hypersensitivity is the triggering of a humoral immune response. Usually the period of that immune response will or can last 7 to 10 days between injection of an antigen and the beginning of the symptom of the patient. So you can see that there are complement system activated and chemotaxis of neutrophil and then damage of the tissue. Now, the type 4 hypersensitivity. This is also termed as a delayed type of hypersensitivity. So the type 4 hypersensitivity has two major phases, yung sensitization phase and the effector phase. So sensitization phase happens usually 1 to 2 weeks after primary contact with antigen. So medyo matagal. Unlike yung type 1 yung 30 to 60 minutes lang ng introduction, yung sensitization phase, yung type 4 hypersensitivity can last for a long period of time. So in sensitization phase, the T helper cells are activated and clonally expanded by antigen presented together with a class 2 major histocompatibility complex on a specific appropriate antigen presenting cell. Example, macrophage or Langerhans cells, which are your dendritic epidermal cells. So generally, the CD4 plus T cells of the Th1 subtype are activated during sensitization and are now designated as T delayed type of hypersensitivity cells. So they are usually Th1 cells generally. So that is the sensitization phase. So nasensitize si T cell nung antigen. Now in the effector phase, which is the second phase of the type 4 hypersensitivity, the TDTH cells will secrete a variety of cytokines and chemokines. For example, interferon gamma, tumor necrosis factor beta, IL-2, IL-3, GM-CSF, and chemokines such as interleukin-8, MCAF, and MIF. So these cytokines and chemokines or chemokines will recruit and activate resting macrophage. So after na-recruit si resting macrophage, so they will be activated. Ngayon, yung activated macrophage will promote phagocytic activity and increased concentration of lytic enzymes for more effective killing. So si activator macrophage will present the antigen and will function now as the primary effector cell. So after the macrophage activation, increased presentation of class 2 MHC molecules, increased tumor necrosis factor receptor, increased oxygen radicals, and increased nitric oxide. So all of these will result to further tissue damage. Now your type 2 hypersensitivity can represent as granuloma formation. So yung granuloma formation happens when there is a prolonged delayed type of hypersensitivity, more prolonged than the usual course of a type 4 hypersensitivity reaction. So the granuloma is a focal aggregate of immune cells that forms in response to a persistent inflammatory stimulus. So usually it demonstrates a compact organization of mature macrophages which may or may not be associated with other inflammatory cell types. So yung granuloma formation begins with an inflammatory trigger such as an infectious pathogen or foreign body. Ano yung pinaka-common, especially sa mga Filipinos? The presence of Mycobacterium tuberculosis. So macrophages will be recruited to the site of inflammation and they will be activated as part of the innate immune response. Ngayon, if the macrophage is recruited and activated and is unable to remove that inflammatory stimulus properly, further immune response will be triggered. So what happens? It will call dendritic cells and increase representation of major histocompatibility complex 2. And more macrophages will go to the site and now the chronic inflammatory reaction happen. So the macrophages will form a tight aggregate around the inflammatory stimulus. So for example, nandito yung Mycobacterium tuberculosis. And that when that happen, they will be surrounded by lymphocytes. And yung lymphocytes can be further surrounded by fibroblasts having a fibrin deposition. So this is like they are now protecting they are trying to contain the foreign body or the infectious pathogen. Now, because of that effective containment, hindi na ngayon ma-detect ng immune system natin yung infectious pathogen. And when that happen, if more granuloma will be formed and they will mature, these granuloma can trigger necrosis to that tissue where they are deposited. So in tuberculous granuloma, usually they are associated with caseating granuloma, in which yung necrotic area will exhibit a cheese-like macroscopic appearance. And this granuloma formation that leads to necrosis is usually what triggers the increased morbidity and transmission of tuberculosis. So remember, your tuberculosis is a type of the presence of Mycobacterium tuberculosis can trigger a type 4 delayed hypersensitivity reaction. And when there is a granuloma formation in pulmonary, we term that as gone focus. So that is your type 4 hypersensitivity reaction. Another type of type 4 hypersensitivity is your contact dermatitis, wherein the skin will have a contact with an allergen that triggers activation of T cells and will cause hypersensitivity reaction in a localized form. So one way of testing for contact dermatitis is patch testing. So we put a specific type of allergen in some amount or in minute amount and observe for delayed type of reaction on the location of that um, type of allergen, and we will now see if the patient is allergic to that kind of allergen. So that is a way of testing for type 4 hypersensitivity reactions. So those are the different types of your hypersensitivity reaction. This is when the immune system reacts in an exaggerated way to a more or less not that harmful type of antigen, causing a tissue injury to the host. Thank you for listening.